at all. Sorry. All right. So I wanted to talk about abdominal pain tonight because it's actually the past couple shifts I've been on, I've gotten confirmed by going on calls with abdominal pain. We go BLS every single time. We never get a medic, and usually it's not going to be something that you need to deal with acutely, but you should know something about it when you see it. You should know what really, really bad things it could be. So the approach, and this is going to be the same as all the other lectures I've given. Just approach the patient. Is the patient stable? And first thing you should be asking yourself is, what are the life threats that you're concerned about? Just give them the dispatch of what you see when you get on scene. And does my patient maybe have one of these horrible things? Do I need a medic? So as soon as you get on scene, you're never getting a medic with abdominal pain. That's part of the problem with this type of dispatch. So as soon as you get on scene, you should make that assessment. Is there something that I could use a medic for so you get it started and not delay transport? And do I need to do lights and sirens transport? We'll talk about that in a little bit. There's a few cases of abdominal pain where that might help. There might be some benefit at the hospital. They could get better in a couple minutes. And then everything else. So the threat down. So these are really, and I went through this a bunch with myself and then a bunch with a doctor that I worked with up at UConn. Now, what things do basic EMTs really need to know about abdominal pain, or what do you need to be aware of? And so an atypical presentation of an MI, a AAA, and we'll go through that. A lot of these are things you've heard of. A ruptured ectopic pregnancy, and a massive GI bleed. And I put these forward. There's a lot of things that abdominal pain could be. Could you die from appendicitis? Of course, but you're not going to die over the course of a transport. You're not going to die. Minutes aren't going to make a difference. So these are the 4 things that maybe minutes make a difference, and maybe you really need to be aware when you get on scene that you might be looking for things. So let's talk a bit about the atypical heart attack. And so it's a classic thing that's drilled into all of us in EMT class. Like, oh, abdominal pain in an elderly woman could be a heart attack. About a third of patients diagnosed with a STEMI or a non-STEMI heart attack, they didn't have chest pain on presentation. So they presented with other things. So who are these people that are going to present with abdominal pain or vague symptoms or things you need to worry about? It's classically the elderly, classically people with diabetes, females, and then people with dementia. And part of that is that you're not going to get a great history. So, and what to look for, so upper abdominal pain. So the heart really sits right on top of the diaphragm. And when it gets inflamed during a heart attack, it can sort of mimic upper abdominal pain. It innervates it has all the same type of innervation as the pancreas in different areas, different things right there. Indigestion are just vague symptoms. A history of cardiac problems and other anginal equivalents. So the things that we look for in every heart attack, so trouble breathing, diaphoresis, nausea, vomiting. So I wanted to talk about a case. So really why I did this lecture in the first place is that the past 2 shifts I've been on, I've had someone, an old woman, with a cardiac history, dispatch was abdominal pain, we got on scene BLS, and it didn't feel right. It felt like I should have had a medic. And so I wanted to talk about this was actually about 2 weeks ago, 84-year-old female, past mental history of a previous heart attack about 10 years ago, and a stroke. And she's got abdominal pain, some nausea and vomiting. And she's pointing kind of like epigastric, maybe in her chest. It's really non-specific. And so the question is, what do? You get there right away. You do a couple options. So you can call the medic. And so that's what we ended up doing for this call. We called the medic, we intercepted. And the reason for that being is that they can do a 12-lead EKG. That's something that we can't do. That's the one that they can do a 12-lead EKG, transfer it to the hospital, and you can rule out an ST elevation MI right away. Someone that might need to go to the cath lab that just presented with abdominal pain. These are some of the other things I put in here. I went through the Stanford Hospital protocols and see what we could do. It seems like, Ron, you can comment on this. AEMT sort of have carte blanche to do IVs in these types of situations. So
even without a medic.
Even without a medic, that's where I'm going with this. So this is a completely appropriate time for you as an AEMT, if you decided not to call a medic, to do an IV. someone with abdominal pain and you're gonna ride it in, that's perfect. You can start at KBO, so you can start a little drip, make it slow just to keep the vein open. The key with this is that don't start the KBO line and delay your transport to a medic or to the hospital because of it. So you're more than welcome to start the KBO line, but it should be on route, or you should have a medic coming to you. So I want to talk about a AAA as well. So this is an abdominal aortic aneurysm, and this becomes a problem when it's ruptured. So we're really talking about an older population here. So you get dispatched for abdominal pain, it's over 50. It should be right in the front of your mind. Could this be a rupturing abdominal aortic aneurysm? So people live with these, the big masses in their abdomen that gets found when they get a CAT scan for something else, or their doctor feels it. But it's something that they live with every day, they don't notice it, it's asymptomatic, and then suddenly they start having pain. And they start having pain because the wall of that artery is starting to split, and they're starting to pour blood into their abdomen. And so this is really the diagnosis that you as an EMT want to be aware of. So pain of the abdomen, blank classically radiates to the back. There's a classic triad, so pain, hypotension, so because they're bleeding so much, they're becoming hypotensive, and feeling a pulsatile mass. This is like, if you don't feel, so when you go up to a patient over 50, you think it might be a AAA, a rupture in AAA, and you feel their abdomen, and you don't feel a pulsatile abdominal mass, that doesn't really mean anything, but if you do, it's nice and reassuring. You're not always going to have this triad. So management of this is the perfect situation for you as an AEMT to get on scene and decide that we should just package and go. There's no reason to call a medic. There's no reason to wait for a medic. You should just start moving. So don't delay transport for an IV. Don't delay transport for a medic. Just go. Ruptured ectopic pregnancy. So did you guys talk about this in the EMT class? I imagine so. So this is something that gets drilled into us a lot up at UConn. That any female that you come across with lower abdominal pain, that's of childbearing age, or someone who even looks like they're of childbearing age, they're having an ectopic pregnancy until you can prove otherwise. And so that pretty much means getting a pregnancy test at the hospital. So the classic history, 30-something-year-old female, lower abdominal pain, they're not sure when their last period was, maybe it was a couple weeks ago, not really sure, and then hypotension if they've had that ectopic pregnancy. So ectopic pregnancy being a pregnancy inside the fallopian tube, it's getting bigger, and then it bursts. So we'll go back to the picture that I had here. So this is just bleeding into the perineum. And this is the same management as a AAA. So just think about what you're looking at. This might be an acute event. AMT can start an IV. There's not really a reason to have a medic on this call. They're not going to offer you anything that you couldn't. And transport life inside of the patient isn't stable. So massive GI bleed. I bring this up because I actually had a call in high school. I was a driver of it. We were a kid crew. We got on scene. It was a mutual aid Norwalk. We get on scene, this lady upstairs in her apartment, completely ashen, and she'd been having dark stools for a couple of days. And she was in shock. We got her downstairs, and the medic that we had on scene, and I couldn't even recognize him now if I saw him, tried 6 times to get an IV on this patient. We sat on scene, tried to get 6 IVs, and the patient ended up coding going into the hospital. So just kind of like a foreboding story, word of warning that people can lose a ton of blood when they're having GI bleeds. That can be from upper or lower. So anywhere right from their esophagus all the way down to the rectum, there's different spots that you can bleed. It's called all different names in your EMT book, but it doesn't really matter. People can lose a ton of blood. So when you're evaluating someone that's either vomiting blood or they've been having bloody diarrhea, Look for signs of shock. So all the things that you're taught about in EMT class. So if they're hypotensive, if they're tachycardic, if their skin looks wrong. And then if they've got signs of anemia or blood loss that you can see. So what you're looking for is pallor of their mucous membranes. And it's actually, so I use this a lot in my own physical exam, and it's pretty good. If you pull people's eyelids down just a little bit so you can see the underneath this part of their eye, get used to what it looks like, you or your friends, it looks pink, it looks really nice. When someone's really anemic or they've lost a lot of blood, it doesn't look right. It looks kind of like gray, not really pink, not really red. So you can check for that. And then just sort of for your own edification, think about where they might be bleeding from. And this matters a little bit in your management. So an upper GI bleed, so this is someone vomiting a ton of blood, having coffee ground emesis, so black blood, so the blood that they were bleeding from their esophagus, from their stomach, gets eaten up by all the things in their stomach, and they vomit that up, and it looks black, or black stool. Now what I wanted to talk about here, which is another emergency, I haven't seen it on a call at post, but it's pretty scary when it does occur. So esophageal varices, there are these big and I don't have a picture of the anatomy, but people who have cirrhotic livers, people who have a history of alcoholism, can get these really big dilated veins in their esophagus. Those can rupture, and it can be pretty disastrous. They can bleed a lot there, and they can actually start having some airway obstruction. So this is one of the situations that I think if you see people vomiting up a ton of blood and you're questioning whether it might be an airway, you might have some problem with airway, you should think about calling for a medic. Lower GI bleed, so red blood in the stool. And then ask, are they on anticoagulants, because that's going to change how quickly things at the hospital are going to move. And this is the same thing as everything else. Just when you're talking about upper GI bleeds, people can have airway problems. Think about calling for a medic. Yeah.
For GI bleed, would you see anything in their glucose level that would give you, a heads up, all of a sudden, their dextrose is 60 and, combined with.
Not necessarily. You're going to get most of what you're looking for from history. So you're going to talk to them like, how have your stools looked? How did are you vomiting? If they're hypotensive and unstable, you're doing the same thing as with any patient. So you're moving quickly, you're treating for shock, you're transporting lights and sirens. And for the most part, there's no reason for you to get a medic, is what I kind of want to hammer in here. There's no reason to delay transport of someone who looks shocky for a medic. Other things that can be bad, but it's not quite as immediate. So a rigid abdomen in a trauma patient. So this is hemoperineum. So someone who, big car accident, they lacerate their spleen, they lacerate their liver, they disrupted some major artery. Their belly will get filled with blood, and when that happens, their abdomen will feel distended and rigid, and that's something that you just move right away if you see it. Things that can also get bad, acute pancreatitis. People who have hypotensive, so that's someone who's having abdominal pain right in the middle of their abdomen. Maybe they've been drinking a lot lately. Would be kind of a classic story. And that can actually start going towards hypotension. And then less immediate, these are things that you can look for in your DMT book with mesenteric ischemia. So that's someone who's, the same way you have cardiac ischemia, you can have intestinal ischemia. It's bad. People can have dead gut inside them. And that's classically people who are having pain way out of proportion to their exam. So you push on them, and it doesn't hurt as much as you might expect, just given how much they're riding around the bed. Perforated viscus, or someone who's perforated some part of their GI tract, so be it an ulcer in their stomach or a little diverticulitis. These can look pretty bad, intestinal obstruction. I want to talk about when to call for a medic. So upper GI bleed, airway management, 12-lead EKG. If you're thinking that this might be a heart attack, as soon as you figure that out, and if you figured it out quick enough, So you're on scene, it's an old lady, cardiac history, shortness of breath, having abdominal pain, not chest pain, abdominal pain. You might as well call for a medic then while you're on scene, get them moving to you. They'll get a 12 lead, they'll look at it, they'll transmit it to the hospital, and that patient will be moving in the direction they need to be moving faster than if you went without them, even lights and sirens to the hospital. I just wanted to bring this up. Paramedics on the trucks have anti-nausea medication, Zofran, you've probably seen it given. This is not a reason to call for a medic, but it's just something to be aware of, that if you call for a medic, they can offer that. But we're on lights and sirens, so I was talking to Dr. Yukon, a guy I work with, about when does this really make sense? When should you throw the patient in the back of the ambulance and drive as quickly as you can to the hospital? There's no reason to do lights and sirens unless the patient's unstable and you feel uncomfortable, the patient is beyond your care, and they need something that you can't provide. It doesn't even matter what you think it is. They're beyond your care. Then you should probably turn on the lights, sirens, and just get moving to the hospital. If something doesn't feel right to you, that's totally appropriate. And if there's some clear benefit to that person getting to the hospital a couple minutes before they would otherwise. So there aren't that many situations that you can pick this out, but someone who's having a heart attack and would be a lot better off getting to the hospital a little bit quicker so they can get to the cath lab, that's a reason to use lights and sirens. Someone's having a stroke and can get to TPA, that's a reason to use lights and sirens. Everything else, there's a lot of gray area there. So this is more of a word of caution that there's not as many reasons out there to turn on the light sirens and barrel down to Stanford Hospital as quickly as you can. There aren't that many situations that really makes sense and the patient's going to derive any benefit from. But that said, if you're in the back of the ambulance and someone's got a low blood pressure and you're not comfortable, by all means, just start moving. But for the rest of it, just take it easy, because they'll get to the hospital, you'll rush to the hospital, you'll save 3 minutes, and then they'll sit next to the registration person for 3 minutes, and they'll get in the bed and they'll wait for the tech, and you'll sit there and like 15 minutes will elapse and no one's seen them, and you'll feel ridiculous. It's not at all worth it. I wanted to do a little bit on the abdominal exam. It's very infrequently that you're on the scene of an emergency and this is an exam that you have time for to really do thoroughly, but I thought I'd go through it very quickly. So I had a volunteer, male volunteer. Male, sneeze your exam. Anyone? Okay. So I want to talk about this. There we go. So I'm going to go through a little bit of anatomy. This is going to be very quick of where things are in the belly. I used to use a mnemonic that I made up during EMT class, GLASS, and that's pretty much all the organs that you really need to think about on the ambulance. So gallbladder and liver, you're not even really thinking about those that much. Appendix, stomach, and spleen is kind of over here, and the rest is the guts. So that's all you really have to know. So I didn't want to talk about specific diagnoses like appendicitis and diverticulitis and all these things you see in your EMT book, because it really doesn't matter. It's not something you really care about. They're not going to die in 15 minutes from it. But just generally, someone has appendicitis or someone has a problem with their gallbladder. In the beginning of it, it's visceral pain, so it starts in the middle. So I don't know, it hurts in here somewhere. I don't really know. And it doesn't really localize to a specific point in their belly until it inflames the peritoneum, so the lining of your whole abdominal cavity. So when the appendix gets angry enough so that it's inflaming the lining of your stomach, the lining of your whole abdominal cavity, then they'll start to be like, oh, it's really down here. This is where it hurts. So you're going to get a lot of people doing a lot of this. That's not very useful. I'm going to quickly go through the abdominal exam, so I'll have your flat here. So, just turn around. I'm used to doing that on the other side. Sorry. Yeah. Always examine from the right side. You can't do that. So for our purposes, there's two there's a couple different types of bellies that you're gonna see that you should be familiar with. So when you just touch someone's abdomen, get a feeling for how firm it is. Can you push at all into it? Is it solid like a rock? Does it feel weird? That's a reason to start moving a little quicker. If someone's abdomen is really distended, like they have a bowel obstruction or they're crazy constipated, their belly can get really big and feel a little harder. But if someone's got blood in their belly, or they've got peritonitis, and they've like ruptured a viscus or their whole belly's infected, that's gonna feel very hard. Their abdominal muscles won't let you go through it all. It's really impressive to feel. Next thing you do, so if you want to get a really good exam, he's pretty strong. It's pretty tough to really feel what's going on here. So if you bend his knees, you're going to get a better exam. So people immediately become a lot softer, and it's a lot easier to do. The first thing you want to get a sense is for how, so if they're riding around in bed, you don't want to start slamming on their belly right away. You want to know, I mean, how little pressure can I put on them and still make them hurt? So just tap a little bit around here. What you're trying to do is just dent the peritoneum. And I tried to find a great picture of the peritoneal lining. It's tough. But you're just trying to dent the lining of the abdomen. So just push a little bit and see if that's hurting. If someone's like, that hurts everywhere, then maybe it's something serious going on. Maybe they've burst something. Maybe they have their whole belly's inflamed. They have peritoneal signs. Another way you can assess that, so you can tap really lightly. That's a way to assess. You can take someone and shake their belly like this, and if just jiggling around their guts hurts, that's a sign of the peritoneum. You can also take someone's leg and tap their heel. And so just tapping their heel makes their belly hurt, that's not a good sign. Going over bumps in the ambulance makes their belly hurt, that's something the hospital's going to want to know, because that's a sign that maybe they have peritonitis. The rest of the exam, I know in EFT class we all did the 2 hands, and I make sure you do each quadrant. It doesn't matter so much. So you can just take a hand and feel everywhere. Have an idea of where they're hurting, but you can just push on them and figure out where it might hurt. Make sure you go pretty low, because that, especially the woman, some of the organs that you're, like ectopic pregnancy type of stuff that you're dealing with, it's all lower, and sometimes you don't feel quite that low. That's about it. Does anyone have any questions about the exam or anything? I wanted to finish up pretty quick. All right, that's about it.
You've had one college education.